Good afternoon. Good evening.
Morning all.
Yeah. Hi everyone. Hi Chica.
Hi, good morning.
Good evening, Christy.
Yeah. Hi Jun. How are you?
Oh, fine.
Afternoon.
Hi Swen. Hi Tangru. And Jatharat. We have our Southeast Asian cohort. Our Central American, our Chinese, our African representatives. Hi Ivan.
Hello.
Nigeria and India.
Oh, okay. Sorry, the competing with that of what they call the space. Barua.
There we go. Hi Julian.
Hi, Christy. Morning all.
Morning, everyone. All right. I put the Menti link in the chat so you can open up an extra browser, and that will be ready when we get going this morning. I'm I'm thrilled to actually have Dr. Sarah Kinter with us today. So you worked on your homework this week as a project that Sarah's actually executed, and I think that so many times we're talking theoretical and it gets hard to think about exposure and disease and outcome, and it's so much more real when we talk about an actual project. And so this homework was really, I think, to have a discussion around, here's a real project, here's a real problem. What was Sarah's approach to designing a study to answer her question? So we both have looked at your homeworks, and I think that we're going to have a very lively discussion today. We had a lot of consistency and some areas where people were really different. So I would also encourage you to pull up your homework or recall your homework so that you can kind of think like, how is it that Sarah got to this one place and I got to this different place? And where you're consistent. So I don't grade these homeworks. I look at them ahead of class because I think it helps to, make sure that class is useful and is addressing issues that come up along the way. We will post an answer key after class so you can see the written answers, not just what our discussion is, if you want to go back and refer to that information. I think first, though, what I wanted to do is spend a little bit of time talking about study design. So again, thank you for so many of you who posted questions in the discussion, because that also, hopefully I posted a number of answers yesterday and through the week. Hopefully I would encourage you to look through the answers to many different people's questions, because I think there's a lot of good questions and a few resources that were posted as well. But I wanted to spend a little bit of time just kind of talking about study design and where people are getting tripped up, and hopefully clarify that. And then we'll spend the rest of the class talking to Sarah about her study. So I'm going to share my screen here. Just 1 second. All right, okay. Can you guys see the screen? Thumbs up? Okay, heads nodding, excellent, all right. Okay, so we'll do some Q&A on study design, talk about the answers to the homework, and then try and take it one step further in terms of thinking about what you would actually collect for this study once we've talked about the basics of the design, so you can discuss that for a little bit. So let's start with a Menti ordering here. So rank order these studies designs by rigor. I'll give you guys a minute to do that. If you have any troubles with Menti, please let me know.
Can you give the link again?
Oh, yeah, Joyce, can you post the link?
Thank you.
Yes, I posted the link.
Thanks. 5. I'll wait a few more minutes here for people to add their answers. It's easier once you see the answers, isn't it? All right. Yeah, so I think collectively you guys have really nailed it. So yeah, this is the order of rigor in these study designs. So I thought that would be nice just to kind of drive that home because we see these things in different ways. All right, so this is a slide that I showed at the end of class last class. And I think it's worth just spending, we were short on time, and I think it's just worth spending a little bit of time here with these different study designs, thinking about when they're executed. So I think the most intuitive design is a randomized clinical trial or a cohort, because we're starting at this time and we're putting people into their bins based on randomization or some exposure and following them over time to see if they develop our disease or our outcome in the future. So we're starting now and we move forward. We're doing the same thing with a retrospective cohort study, except that everything's happened in the past. So we have our exposure and we know based on the data that we have that occurred before our outcome. And we're classifying people based on an exposure of interest and following them over time. So there's a lot of questions about what's the difference between a retrospective cohort study and a case control study. They both happen in the past. And that's true, like both disease outcomes have occurred when you do these studies. That I think you can see that the arrows are pointing in different directions. And so what that denotes is that in a cohort study, we're first choosing people in a general cohort, a defined cohort or a defined group of people, but then or on exposure. So we're first identifying people without the disease, and then we're following them over time. Even though it's in the past, we have some indicator of time, and we can see when their outcome occurred at a later date. Whereas, and so as in the case control study, we're selecting people based on their disease status. So people in our study are being selected based on whether or not they have the disease or they do not, or the outcome of interest. And then we're looking back towards and measuring their exposure. So what it really has to do with this difference between retrospective cohort studies and case control studies is how we select our participants to be in our study when we're enrolling them. And so if you're seeing a study where they've selected people who either have a disease or do not, or have your outcome or do not, think a case control study. If you're looking at a study where they're following people over time and they are classifying people not based on their disease status, but based on some factor, some other exposure of interest, then you should start thinking about a retrospective cohort study if it's all been in the past. There were also a few questions around a case control study versus a cross-sectional study. So in a cross-sectional study, we're measuring our disease and exposure at the same time, essentially. And then we're just putting people into bins. So I have a few slides to illustrate these a little bit more. So here's a retrospective cohort study, and this is an actual trying to kind of give you an example of this. So on the next slide, I have the reference. This is a retrospective cohort study that I posted as an example in module 2. And this was a study based in Germany where they took everybody with a cleft palate in their clinic who was seen between 2009 and 2019. And they classified them based on several exposures. In this case, the exposure is their weight status at the time of surgery. And so they either had an okay weight or they were classified as underweight. They had the surgery, and then the outcome that they were interested in was looking at fistula. And so basically, this is how this has all happened in the past, because in, say, 2020, they went to their records and they looked at every single patient in their clinic who had this surgery, and then looked at, abstracted the weight from the record, and then looked at whether or not they developed fistula over some period of time. So this is we know that the fistula happened after the surgery, right? So we know there is this dimension of time that's really clear. We also know that the weight was taken at the time of surgery. So we know that there's the temporality in this design, that the weight preceded the outcome. And so this would be an example of a retrospective cohort study. Everything happened before, and we're using existing records to abstract this from and to create our cohort and to look at outcomes based on this particular exposure. So if you haven't, and you're trying to understand this design a little bit more, I would encourage you to look at this manuscript here. And maybe it must have been a different year range than I had, because this was published in 2013. So it's probably 1990. I know it's like a 10-year period, so I'll have to change that next time around. But anyway, the same principle applies. All of this happened in the past. All right. Any questions about that? I can see the chat, so if you do, please chime in now or later. Okay, so here's an example of a case control study. This is also drawn from the example in module 3. This was a case control study looking at multiple birth defects, but one of them was cleft. And they were looking at, they're interested to learn whether or not individuals who took a folic acid antagonist during pregnancy had a higher risk of cleft. That was their question. And there was somebody who I think had asked about, can we use both, just choose whether we do a case control study or a cohort study? In some cases, yes. In the case of cleft and etiology, that's really uncommon. And the reason is that cleft occurs about in 1 in 700 live births. And so if you want to do a cohort study, you would need 70,000 women to identify 100 cases of cleft. So it's not particularly feasible. So when it comes to studies of etiology, we typically will do case control studies. So it's happened, we already can identify the individuals who were born with a cleft, and then we can take a sample of those not born with a cleft, or that meet some other criteria. And but they don't have a cleft, and so we're choosing people in this design based on their outcome, and then we're looking back to see, like, well, did they take this type of medication that could interfere with folic acid, and classify them that way. So in this case, we're selecting people into our study based on whether or not they had the outcome that we're interested in, and then looking back. So hopefully that adds some clarity to the difference. So let's see, in the example of fistula, would there be a control group? Myra, that's a great question. Let's go back to that really quickly here. So what we have is a comparison group. I think a lot of people will say in cohort studies there's a control group, but in epi speak, I guess I think of controls as in case control studies. And I think of this as unexposed. So we have comparisons, and the comparison is whether or not they had an okay weight versus they were underweight. But I don't think of them as controls. I think of them based on exposure, and then moving forward to see if they develop the outcome. When we talk about controls, we're usually talking about a case control study. So I think it might be a little bit of terminology, but we're comparing our cases to our controls. So we still have a comparison with our case control studies. It's a good question. All right. Any other questions, please post in the chat. And this is the manuscript that's posted in Canvas as an example of this. All right, so here's another Menti question. This study design, you can choose multiple. First selects participants on the basis of having or not having an exposure and then follows them over time. I'll give you a minute to get back to your Menti. And Joyce reposted the link in the chat. All right. Okay, were you guys able to choose more than one? No. Okay, I think that might be a problem. That was an error, a user error on my part. So you're right, a prospective cohort study selects participants on the basis of having an exposure, as do retrospective cohort studies. So both of these studies designs, and that may have just been an error in the program here. We don't select our participants on exposure for a case control study or a cross-sectional study. We classify them, but in a case control study, we're selecting people based on their disease status. So you should have been able to pick 2 here. I'm sorry about that. I'll change that up next time. All right, and this has 1 answer. So this study design first selects participants with and without the outcome. All right, yep. We've got majority are here, case control studies, cross-sectional studies. Yeah, so in this particular study design, we're first choosing people, that's a case control study. And I think that the key here is that we're first selecting them based on disease status. I'll talk about cross-sectional studies next, but we're sort of simultaneously classifying people in a cross-sectional study based on their disease and their exposure status. Whereas case control studies is we're selecting people who do and do not have the outcome, and that's how they're getting into the study to begin with. So yeah, all right. Okay, so this is a cross-sectional study. So I think what sets this apart from our other study designs is that we have some sort of defined population. So in this case, I guess I would think about, say, a general dentist practice or multiple dental practices. And as a routine, they do periodontal exams and they collect as a questionnaire when people come into clinic about their oral health related quality of life. And so they're getting a perio exam and they're measuring quality of life at the time they get their perio exam. And what the investigator does in this case is takes everybody in their clinic from some certain time period and just abstracts all this information. So you have a measure of what their periodontal disease is, as well as their quality of life on this entire population, and you're just putting them into bins. So you're not selecting people based on whether or not they have a disease or an outcome, you're defining a population and then you're putting them into bins based on their status on these two factors. So in the case of a cross-sectional study, we have more issues with temporality. We're collecting prevalent cases. So just at that moment in time when you're measuring it, whether or not they have perio and quality of life. So we're not actually selecting folks based on disease or exposure status in the cross-sectional study. We're defining a population and then we're putting them into these different bins based on their status. Right, any questions about that? So if any of you have any follow-up questions, please post these in the discussion. I'll definitely follow up and answer them. And I think if you read through the discussion, there were lots of questions about the differences between these three types of study designs. And hopefully I answered the questions and you can see, kind of have a little more chance to think about it, because I think sometimes with these study designs, you just need to hear it multiple times in multiple ways. And that can be orally and written and in different ways. So hopefully this has helped answer some questions about study design. All right, so I'm going to go ahead and stop my share. Any other questions? Okay, all right. Okay, so let's go to the homework, because I think this is also one of my favorite exercises in the course. I think it really gives you the chance to kind of think through some of the issues. I'm just going to ask, so if you have your homework at the ready, that would be really great. And if you have questions, I'm going to just ask Sarah about what her thoughts are on these different questions. And if anything doesn't resonate, or if you got a different answer and you're wondering how it is that she came up with the decision that she did, that please post in the chat and we'll be monitoring that and we can talk about it. All right, so Sarah, what was your general question of interest?
I was interested in whether or not there was a difference in prevalence of VPI following the two different surgical approaches to maxillary advancement surgery.
Okay, I think most people got that pretty well outlined in their homeworks. Like I think the clinical question, most of you really seemed to get that it was pretty straightforward. And so how would you frame your statistical hypothesis, your research hypothesis?
I framed it as, based on reading the literature, that there would be higher prevalence among those who had the traditional or conventional advancement than there would be in the group that had distraction.
Okay. And that was just based on the literature?
That was based on the literature and what is known about the indication for doing distraction versus traditional advancement. There is some literature out there that talks about distraction having a lower risk of BPI because there is movement over time versus the movement all occurring in a single procedure or on block. And so that was where that hypothesis came from.
All right, great.
As far as using, the results of other studies to get that hypothesis, that the current literature is, it actually reports both. There is no difference. It reports that there is higher in the distraction group and not the traditional group. And then there are other studies that say that it's higher in the traditional group and not conventional. So I went with the theory that was out there, because that was really what I was, I had a clinical opinion about what that was. And so I went to the literature, took a look to see what was there and the rationale for choosing one over the other, and went with that.
Yeah, so I think this is a nice example of just identifying the gaps in knowledge, and also using, because Sarah's a clinician, she's a clinician scientist, she sort of had that clinical perspective that she could bring to the table as well. All right, let's go through PICO, but I want to go through each letter because people sort of got tripped up on what is the PICO question here, right? So let's go with P. Who's the population, Sarah?
The population are any teens or young adults who are having maxillary advancement surgery of either type, who all have some type of cleft palate, regardless of syndrome diagnosis.
Okay, yeah, and they were seen at Children's, is that right?
That we're seeing, yes, sorry, if that were seen at Children's and that had surgery between 2007 and 2019.
Okay, great. So we mean Seattle Children's. I know there's many
Yes.
children's hospitals in the world.
I did that
We're
at
just at the
ACPA
same
this
place,
year,
so
yeah.
we just have that colloquial. All right, okay, great. I
Excuse
think, yeah.
So the patients had already had the surgery.
Yes, so it ended, well, I don't know if you want me to disclose the study design
Okay,
yet,
go ahead.
Dr. McKinney, but
Okay,
Yeah, we're getting there. All right.
Okay.
But I do think that sometimes it's a little hard to sort out what is the exposure, what's the defined population, and then what's the exposure and the comparison. So let's start with, so I think Sarah did a great job of explaining like what the frame, the sampling frame was, who was potentially eligible for this study. Sarah, what was the exposure?
the exposure was having distraction. And then the unexposed in the other group or the comparator group were those that had the conventional distraction or traditional advancement. Or sorry, not conventional distraction, traditional advancement.
Yeah, so exposure was DO, right?
Mm-hmm.
And then the comparison was the TMA.
Yep.
So how do you, those are the two things, and I think like if you struggled with this, because many people did, think about what's being compared. What do you want to compare? And so Sarah, could your exposure have been TMA and your comparison been DO?
It could have been, yeah. I could have done it that way. And that was based on like the hypothesis that I had. But it could have been done, yeah. It could have been done either way.
You can do it either way. I think one thing to think about too is, you know, a lot of times when we talk about our exposure, or we're thinking who either has the highest risk or the lowest risk. It's often the highest. Who we think has a better out. It just depends on how you want to think of it. I guess just know that you could do it either way. Yeah, Julian, you have a question.
Thank you. I just want to share my rationale about that because I understand that we can use either way, but my rationale was using the highest exposure or the worst exposure as the E in this case, the traditional, because I was expecting a worse scenario than the control, which is DO. So just want to share.
Yeah, and that's absolutely fine. And Sarah expected the same thing. She just flipped it. So she expected there to be less risk with DO and put that as her exposure. So either one is fine. And I think that the important thing in my mind when I'm thinking about study design is to have a direction. So a lot of times, and I saw this a little bit with the research hypothesis, which I think is people stating the null hypothesis, so that there would be no difference between these two types of surgeries, which is it's fine. And when statistically, that's how we frame it. So that's not wrong. But I think when we're writing up our project planner, when we are writing grants, we want to anticipate the direction that DO would have better outcomes than TMA, for example.
so that's kind of the key, and that came from the literature. When you're formulating that PICO, is kind of knowing clinically what you expect to see.
Yeah.
Oh, okay, Sarah, go ahead.
I also would say that so the TMA group, that was the more the surgery with more longevity, like that had been the one that had been used, and then distraction had been developed to address these kids with cleft who needed such a huge amount of advancement. And so that's another reason why, I don't know that I was fully aware of it at the time. That's another reason why I chose distraction as the exposure group, because that was the new technique, newish technique that I was looking at.
See,
Julian?
Yes, I want to say that I do agree with Sarah because DO is the newest technique. So thinking about that point of view, it will make sense to consider that at this point. Yeah.
Yeah, and like in RCTs, a lot of time our comparison is the standard, like standard of care, or what we normally do is what we think, and we're comparing something new to it. So I think that makes good sense. Oh, your outcome.
Outcome was VPI.
Mhm.
Yeah, presence of VPI.
Yeah, and the time. Lots of people had questions about this.
Yeah, so what was important was it was possible that VPI could be present before this particular surgery. And so another criteria for this particular analysis was that there was not VPI present before surgery, because I wanted to make sure that I was capturing VPI that was associated with the maxillary advancement procedure and wasn't there already. And so time-wise, they had no VPI before maxillary advancement surgery, then they had surgery, and then there was VPI present after that procedure.
Yeah. And how long after did you measure it?
Our clinical protocol is to see patients 3 months after surgery. In the case of distraction, it's 3 months after the distractors are removed.
And is that, will you capture all those who develop VPI by looking 3 months after? Is that a good, like, how was that time point selected?
Yeah, and again, in the literature, I mean, it's not a huge breadth of literature, but again, there is indication that by the time 3 months have passed, that any spontaneous change is no longer going to occur. And the quality of life side of that too is we don't want to wait around too long in late teens who have a change in their speech to address it. And so that clinically at our institution at 3 months, we are measuring the outcome and then acting on it if it's problematic.
Okay, great. Any questions about that time piece? I'm not, you know, there wasn't necessarily like, you know, that wasn't specified in the background. I think that's just based on clinical understanding of how long these things take to arise and when a good time to measure it is. Taranya, you have a question.
Yes, I have some thoughts on both the VPI part and as well as the timeline taken to assess these things. So in especially cleft children, it's very, very difficult to find someone without a VPI who will be needing maxillary advancement in our clinical setting, in my experience. So instead of assessing with or without VPI, we could just assess them as a velopharyngeal closure pattern, whether it's closing better or closing worse before and after the procedure. And there are different ways to quantify that, one of which is your speech analysis, as well as your nasoendoscopy and video fluoroscopy. So that will give you, you know, probably you may not have difficulties in including samples like, you know, the patients into the study. That's one thing. And second thing, I think it's more reasonable to look at long-term effects as well, because in distraction osteogenesis, you are actually stretching the tissue. So indirectly, you may be subjecting them to some sort of scarring, and then like it's more reasonable to look at long-term effects of at least over a year, ideally 18 months plus.
Mhm.
Yeah, so
Yeah.
certainly, yeah.
Yeah,
for
so a couple things. Like I mentioned, so in our cohort, the prevalence of VPI following palate repair is 10% or so. And also these patients are much older than we would typically assess like outcome after palate repair. And so if they had VPI after surgery, they have had VPI surgery to correct. If they have VPI after palate repair, they've had surgery to correct that already. And so there was definitely a group of patients that needed to be excluded from this analysis because they had pre-op VPI, but it's a good point in understanding your population and what you can and can't assess. The choice for VPI and not nasendoscopy or some sort of instrumental assessment was because the gold standard for assessing whether or not VPI is present is the perceptual evaluation by a trained speech pathologist. That, of course, is problematic if you don't have easy access to a speech pathologist who is trained in this. The difficulty, though, is that, like you mentioned, like closure pattern and whether or not it's closing better or worse than it was before surgery. The closure pattern and even the size of the gap is not necessarily indicative of the severity of VPI that is present. And so there's just a lot of challenges. And I think your questions really speak to understanding who are the patients you have access to, what are your clinical protocols and indications that exist at your institution. And you would have made different choices than I did based on the cohort that you are very familiar with at your institution.
I think that's
I take your point. Thank you.
Mhm.
Yeah, I mean, I think it's a nice example of how, you know, the context matters, right? Where we're doing our studies, who our patients are, and what their status is has to be considered when you're planning your own studies, and that you might end up with a different type of question if you don't have a speech language pathologist, if everybody who's presenting for these procedures already has VPI. And so, I think it's just a nice illustration of that you really have to think about your own context and your own patient population when you're designing your study. Yeah. Okay, Sarah is, I think we talked a little bit about why you chose that. Is VPI a surrogate outcome or is it a true outcome? There's lots of different opinions on this front.
Yeah, I would consider it a true outcome. And I say that because I think in many studies sometimes, especially if they're using like administrative databases, they will use whether or not the patient had VPI surgery as the outcome. And I would consider that a surrogate outcome because it doesn't capture the true burden of VPI, because not everybody chooses to have surgery for VPI, and it doesn't mean that it didn't change things for them with this new speech characteristics after this particular procedure. The other thing I wanted, just looking through briefly at people's responses, there was some people thought about use of speech intelligibility as the outcome. I don't know how many, if any, speech pathologists are on this call, but speech intelligibility, the way that is written, I would probably write it differently now. The way that was written, it was written for an audience of epidemiologists who don't do anything related to speech. And so I was trying to be clear in what I was talking about, in that there is a negative impact to kind of overall ability to communicate and be understood or accepted based on their speech. But speech intelligibility, when you look at literature, the real definition of it is how many syllables do you understand in a certain sample? And clearly the burden of assessing that is really high. And there are many, many factors that go into intelligibility. And a specific challenge with this particular surgery I was interested in was there can be an improvement in like tongue placement for sounds, which can improve intelligibility, but VPI can have a negative impact on intelligibility. And so I was really interested in the change in VPI, and I didn't have good data to support changes related to the articulation. And so I just didn't go there at all with this one.
Sarah, you also mentioned that that VPI as an outcome has implicated, like it is a marker for quality of life. Can you talk a little bit about that, in what way it denotes quality of life?
Yeah, so there can be some degree of hypernasality, and a clinician might rate it mild, but depending on, if the person wants to be, a public speaker, some limited degree of nasality from a clinical perspective is really a big change for them, and could impact what they want to do in their career. And of course, that impacts their quality of life much more than someone who is not going to be looking ahead to a profession that relies on their speech. The other piece is that people can make, even if you can understand everything they're saying, that you can tell that there's something different about how they sound. And that can be, and that's another reason why intelligibility is not always a great measure. People can make judgments based on how we sound when we talk, based on, they will assume things about intelligence, worthiness of what the message is. There can be a lot of things that go into that, and it's not, it is really important to understand, going into having a surgery that could potentially change how you are used to communicating with people around you, is a big deal. And it's why we do measure quality of life around VPI specifically.
Great. All right. So study design. I think I saw almost every study design listed, and I saw people suggest a randomized clinical trial. I saw both types of cohort studies, retrospective and prospective. I saw answers that said cross-sectional study. Sarah, what is your study design? And then let's kind of walk through, maybe you can walk us through like your consideration of all these other designs and how you landed on where you landed.
Sure. I ended up doing a retrospective cohort study. And logistically, the reasons for that were because I had access to a data set that made the temporality very clear as far as presence of VPI that was related to the surgery and not to other causes, or that was pre-existing. I was also in a doctoral program, and the timeline needed to get enough of a patient population in like a prospective cohort study was longer than I wanted to be in school for. And funding wise, having access to a data set that was sitting there that was free made much more sense than the amount of money. It's expensive to do a prospective cohort study. There are certainly benefits to that though, and I have plans to do something like that in the future. And learned a lot from doing the retrospective cohort study first. Randomized controlled trial, yes, that's the gold standard as far as research. However, a couple things, we have 6 surgeons, I believe, that do these surgeries. And so getting all of those surgeons on board to randomized to one surgery or the other was just not reasonable. Also, because the literature doesn't really clearly support one over the other, this particular question is not ready for an RCT. Cross-sectional study design would have been possible, but I wanted to make sure I knew that the VPI I was assessing as the outcome or indicating as the outcome was related to the surgery and not pre-existing. And it was really important to me to be able to make that distinction because VPI can exist for other reasons. And what am I forgetting? Oh, case series. Well, the level of evidence in a case series, we were beyond like just needing to support to the research community that there is a difference in VPI prevalence after these surgeries. We kind of already had accepted that. And the question was, how and why did this happen? And does it relate at all to the surgical technique? Case control, I actually did talk with my mentor about that. And in this particular cohort, the prevalence of VPI, the outcome is not rare. And so that was an indication that I did not need to do a case control study. The other factor was the analysis that needs to be done for a case control is not easily interpretable to my field. And I wanted to make the results that I was reporting understandable and easily digestible to those that were reading my results.
Sarah, in the homework, it said something about a lot of the other studies that were done retrospectively, and there were problems with the methodologies. Did you take that into consideration when you were thinking about doing retrospective?
Yeah, so the challenges with the methodologies were a few things. The study samples were very small. So there's been one RCT done actually for this question, but there were a total of 10 patients in each group. And I had 200 subjects for this particular study. Okay. The other piece was in the literature, there were very few that took into account confounding. So I'm sorry, my dog is making noise. The other things were, that could have, maybe it's not the surgery, maybe it's the amount of the advancement that is moving. And so I needed to be able to account for that in the analysis, and many of the papers out there don't. They run like a t-test or a t-test equivalent just to look at difference in means between groups, but I wanted to be able to account for the other things that could be impacting it to make sure I was comparing groups. I was comparing apples to apples and not apples to oranges.
So what statistics did you use?
I used something called Poisson regression. So it is linear regression, and it gave me the comparison. It gave me a prevalence ratio. So the ratio, the prevalence of VPI in the distraction group versus the prevalence of VPI in the traditional group. And then I adjusted for amount of advancement as well as type of cleft in the regression analyses.
So just a couple of thoughts that I want to reflect on. I think, Sarah, that all of that was fabulous. I think a couple of things it really illustrates is in a real world setting is how feasibility is an important consideration when we're thinking about our studies. That, I've had mentors tell me like, well, if you can't get the patients, if you can't do the study, what use is the most beautifully designed project, right? So if you can't get individuals to randomize, if you don't have 10 years to do your PhD, most of us don't. These are all like the real world considerations, for our animal researchers, we don't often have to think about these things, but and the other thing is, it wasn't just feasible, but she's addressing a gap in knowledge with a larger sample size, by addressing many of the limitations that currently exist. And so, and thinking about it in a way that really does position this study to add new knowledge and use the highest level of study design and evidence that she could with the data that was available to her, which is a retrospective cohort study. So, that gives you the temporality is clear in terms of what happened when. That's a huge addition that we often lack when we do case cross-sectional studies or even case control studies. There's a lot more questions around when things happened. So, and just so kind of putting it in the framework of what you're learning, I think it's a really nice example of how feasibility is used to, and gaps in knowledge are used to identify the strongest study design that can be executed in a particular context. Are there any questions around that?
Who's doing these prospective studies that can take 5 or 10 years?
Yeah. Sarah?
For this particular question, no one that I'm aware
Okay.
of. But so I'm involved in a couple other studies though that are looking at different surgical outcomes in a similar cohort, just younger kids, and they are 5-year studies. The number of people involved, they're multi-site, so there's 16 sites involved to get the amount of people that we need. And I also got advice too from mentors as I was looking at this, because I was like, well, we need multi-site or I'm going to be in school forever. And the advice I got was, yes, that's going to be really important, but maybe not, doesn't make the most sense for right now. We've got study coordinators. The way that we need to get the speech data is very detailed and very labor intensive. And it's a really big undertaking. And I think I don't remember the amount on the grant itself, but it's over $1 million over 5 years. So it's a really big undertaking. To do that. It is really important. But in order to really clearly define and design a prospective study, we need these smaller and retrospective studies to really understand and inform and create a better design later. Yeah. I will admit, I had difficulties doing retrospective for my dissertation just because I felt like I should be doing something higher with what I felt to be higher. But my mentor is very wise, and he was very clear in saying that there's a place for all of this. All of these study designs have a role. Yeah.
I'm thinking of a particular project that I might want to do that sounds kind of similar to your design, and I'm thinking, gosh, wouldn't it be great if we could do it prospectively? But yeah. That I guess you'd have to be in academics for a very long time, or I don't know.
Yeah, I mean, you need, to get a lot of centers involved, you need, contacts at all the different institutions and buy-in, and there's lots of things to think about as far as defining variables. So what one person says is, is this type of surgery might not be the same as what another surgeon says is this type of surgery. And so then you have to be thinking about recording surgeries, and that's a whole other thing. And there's just a lot of details that come up prospectively.
Yeah, I would just add to that, there's a lot of tension too around the timelines for our funding, because most of our research depends on funders to give us the money to do the work. And those grants are often like 5 years. So that's start to finish. That's, from, IRB approval to public, getting your results published. ideally, although it usually is in year 6 or year 7 where those results get published.
Gonna say, yeah.
But there's this tension, like you need a certain number of cases, and you really typically you have to enroll them all, especially if you're doing a prospective cohort. If your follow-up is 3 months, that's great, because then you have more time to recruit, right? You can recruit for 4 years and have follow-up 3 months and finish everybody within 4 years and 3 months. But if your follow-up, like something say like dental caries, where it takes a couple of years, you have to recruit everybody like in year 1. So you have at least 2 years to follow up to look at, new caries rates. And so, so that's where when we have rare diseases or when our timelines are long, we need more sites. And more sites are expensive, like Sarah said. There's a lot of coordination that has to happen, and make sure you're measuring things in the exact same way. And just having the personnel. Most of our studies, that the biggest cost is personnel time, the time it takes everybody to do the work.
Yeah.
So just kind of a bigger perspective on prospective studies, and it, the cost is not much less than a randomized clinical trial for a prospective cohort study. I think, most of these prospective cohort studies at our institute in the United States, their grant caps, they without special approval, you can request $500,000 a year, and that easily is spent in a multi-site study.
My subject, and we can talk about, I would like to talk in some office hours sometimes, but my subject is way less complicated than what you guys are, dealing with these surgical things and left lip and palate patients.
Yeah, I mean, there's always complexity, right? With whatever study, even when it's a common outcome, So I think it's one of the reasons, and Sarah, maybe you can speak to this. Who was part of your team on your study? Who else was represented on the work that you were doing?
The research team. Let's see, I had a data analyst involved who created a REDCap database, so I could put all the data in one place. And then there was I did all the statistics myself, but I had a mentorship group who was helping me do that. And then there were just some data support people that got me the existing data from the different sources I needed it from. But that was really it. I didn't really need a study coordinator because I didn't have to consent people because it was all retrospective. It was all what do they call it? Anyway, the IRB said that you can do this study because you don't have to contact the patients directly. The IRB also at our institution can take a long time, but there is something called expedited review, which makes things go faster. And this particular study, because it was all retrospective data that existed, it qualified for expedited review. And so it was done faster than it normally would have been for a prospective study. So just another factor to account for as far as your timeline goes.
Are there other questions? I think rather than small groups, maybe Sarah will just ask you about your measurements. What did you collect, and where did you get it from, and how did you standardize your measurements?
So the outcome, VPI is measured on a Likert scale. So it's a normal, minimal, mild, moderate, severe rating scale. And we use something called the CAPS AM rating scale, which is a validated rating scale. So there are definitions for each level of severity. However, even with 200 subjects, I didn't have enough subjects by the time we whittled it down to to the groups and adjusted for things to be able to look at like, the risk of going from, mild to severe VPI, et cetera. And so I ended up taking it down to just a binary outcome. And so I divided that by normal and minimal because as the no VPI group, because minimal tends to be a group that we would never do surgery for. And it tends to be something that we can only hear with like auscultation and not just listening. And then the group that was the plus VPI group was those that had mild, moderate, or severe VPI after surgery. The exposures were defined by the operative notes. So I went back myself, I went back to all the operative notes and confirmed the surgery type. All of this data was in the databases, but to make sure that I was getting the right information, I went back to the notes directly for all of the exposure and outcome measurements. The type of cleft came from a database that exists at our center, and I know that data really well, and I am confident in that data and where it came from. So I did not go back to the notes to look specifically at type of cleft. The amount of maxillary advancement. Part of our clinical protocol is to do preoperative lateral cephalometric x-rays and then post-op. And so I went back to those x-rays and did the measurements. And there's an orthodontist that's involved who did the measurements. It was not me. So that's not fair. I forgot that he did that. It's been a little while and it's really early in the morning here, but so the amount of advancement was measured based on the difference between, so this is another really clear point. So I wanted to look at the amount of advancement that was predicted before the surgery, not the actual amount of advancement that occurred. Many of the studies out there, when they are looking at amount of advancement as a factor, they are measuring the pre versus post measurements, which is important. But I wanted to know going into this, what was the information we could give the families for the risks? And so I only wanted to use things that we knew before the surgery had actually occurred. And so the amount of advancement was measured from the difference between a point, so right here on the lip or on the maxilla, and then down on the bottom. So the difference between those two measurements, those number of millimeters, was how far we define that. There's a lot of different ways to define that, though, as I discovered in this. And then, of course, I had to run reliability on those measurements. I also ran reliability on the speech data as well to ensure that there was some confidence that what we were measuring was accurate and reliable. Those were really the primary measurements: the amount of advancement, cleft type, VPI, severity, and the surgery. It's the surgery type.
And Sarah, did you use REDCap? Did you sort of systematically abstract the data? How did you collect your data?
So the first step was data existed in 2 different databases. And so all of our speech data that we collect clinically gets put into a database. And so I had access to that. And then, as I mentioned, there's also a database that exists in our craniofacial center. And so I had access to that, and I combined those. But knowing that knowing a lot about the data and the weaknesses in the data, that was why I went back to directly to the electronic medical record for some of the variables to make sure I had accurate information. Surgery type was one that I knew that I was going to have to go back for. I did use REDCap. I used REDCap more to get, because I had a very specific analysis I wanted to do on the lateral cephs. And so I created that analysis in the Dolphin software. But I created had somebody create a REDCap database to take all the measurements from each patient that I could copy and paste into REDCap. So that I was not manually entering that like into an Excel sheet or something. And then I was able to combine the data set I got off of REDCap with the data sets I got. So I was basically combining 3 data files together when all was said and done.
Great. So for those of you, I'm not sure if you've all heard of REDCap. So we'll take a minute to introduce it. REDCap is a free software that allows you to systematically, you can create your own database for your own study. The REDCap software is available globally. It is hosted at an institution. So it's not something you can just download on your own. And the reason that is the case is these are it was designed for human subjects research. And they want to make sure that the data that is put into these databases have gone through appropriate ethical approvals. So there are, I'm not sure, let's see, 145 countries and many institutions within these countries who have REDCap installations. And so it's actually not that hard to get access to REDCap. If you don't, and it's very easy to set up. I've worked with clinicians who have been able to set up their own REDCap database within a day. It's very intuitive and it can be very complicated as well, but it doesn't have to be. And it's a great way. You can send surveys. You can track people over time. It has some sophisticated tools, but it also can be really simple. And actually, I used REDCap for our pre-program assessment, but it didn't embed very well into Canvas. But it's a wonderful tool. There's Project REDCap. I put the link to everyone in the chat. Julian, you have a question about REDCap or anything?
Yes, thank you. I just want to ask something because I participated in a bid court internationally like 2 years ago because of the COVID-19 pandemic. The principal investigator sent us the REDCap link to use it, but I didn't understand how it works. So the question that I have is, using the REDCap is based on an institutional user, or is it possible as a principal investigator or individual researcher to use it for a clinical study?
You could use it for a clinical study. You have to use a institution's REDCap, but you can start your own REDCap project within your institution. So like the University of Washington has its own REDCap. Seattle Children's Hospital has its own REDCap. I think Khon Kaen University in Northeast Thailand, it has its own REDCap. So,
I'm sorry, but I have a question about that because we use the REDCap from Birmingham University. If I'm doing some kind of multicentric study, for example, the main REDCap that I'm going to use is the REDCap of the principal investigator then, and the other institutions should use that REDCap, or they have to have their own institutional REDCap. That's the concern.
Yeah, so let me, if I'm understanding right, so for that particular project, it would be the PI's REDCap.
Oh, okay, perfect.
And they would give you access. Yeah.
Thank you.
I don't know. Does it have to be the PI's REDCap, or it's whoever you decide is your data coordinating center, if it's a multi-center study?
Yeah, there are different models. So in some cases, like if you were doing an international multi-site study, you can set it up so that if it's your patient and you're the site PI, you're the PI of your clinic or your institution, that you have REDCap and only you see what your patient data is and you give it, it's linked to this other project. So it can work. There are different models that can work. It doesn't, I mean, it sounds like if a PI develops it and sends it out, they probably have IRB approval for it to work that way. But when there are different IRBs involved, you can have different models.
And it's very powerful because I remember we were 16,000 co-authors at the same time putting in, making the input of the patient data following during 30 days after surgery.
Yeah.
And the sponsor was COVID. So I found that really powerful, but I didn't know that it was possible to access REDCap that way. So thank you.
Yeah. Yeah. So Marina's question, what if I'm working in an institution that doesn't have REDCap? Yeah. So then I think the best thing is to develop a collegial relationship with someone who is at an institution that does have REDCap. And, you know, like if I have a student who's in Ghana, I can give them a REDCap project. I'm the listed person at the University of Washington, but they can do everything with it. So it's often the case that you have collaborators at institutions that have a REDCap and they can give you full access to a REDCap database and, you know, collaborate with you on it. So that's I think a way to get around it. I think you'd be surprised if you look at the map, how many REDCap countries there are and how many excuse me, institutions around the world have REDCap installations. So I mean, it may be that your institution doesn't, but you're near someone who does. I would bank on it. Let's see. So Lita, the same question. And in Senegal, I'm not sure. I think I can find a map of where REDCap installations are, and I'll post that for folks. So you can see where REDCap exists. And if you don't, you might know somebody at a sister institution or a neighboring institution that does have REDCap. But it is
There's also
really
a link
powerful.
on here on how to join the REDCap consortium. So maybe if your site doesn't have it, you could work on the process to get them to have it.
Yeah, I think you can. And I don't know if there's a cost. I don't think if there is a cost, it's not very much. The whole intent was to make this available at low cost. There does have to be somebody at your institution that will own it. So you need some sort of data manager, informatics person at your institution who will support it and sort of comply with the guidelines that REDCap sets forth. Does REDCap allow sharing data from different institutions? Yes, absolutely. So, and that is really defined by your IRB. Tanger, that's a great question. So you have to, when you're thinking about your REDCap installation and the different sites, if it's within the same country, it can be a little more straightforward. But sometimes sites want to maintain their own, they don't want to release the personal health information, the names, the date of birth, those sorts of things. And so there's coordination with the ethics on what data will be shared and sort of agreements with your other sites about how the database will be set up. But you can, as PI, like it sounds like in the case of a simple survey that's being distributed widely, you may want one REDCap. It's a link. You send it out to hundreds, thousands of people. They can all answer it. Great. But when it comes to clinical data, when you're collecting personal health information, you may want to be more thoughtful about what's shared between REDCap versions, I guess, if you will. So it is definitely possible. So, and you'll need to talk to your ethics board a little and sort that piece of it out. But people do it all the time. It's a great way to collaborate because people can see, you can see easily how many people a certain site is enrolled, what their data collection looks like. As a PI, you can see what kind of data you're getting from different sites as well. So it can be a useful monitoring tool. Just gonna see if I could come up with a map really quick. I guess we're at 7:15.
I'm on the map. There's actually 6 institutions in Senegal that have REDCap.
Okay.
So if you're on the REDCap website that Dr. McKinney sent out, you can hover over the map there and it will tell you which institutions in that country have REDCap.
All right, great. So I think just briefly, we'll depart. I think we have ethics this coming week with Katie Porter. So that module will be outlined and published really soon, and like sometime today. And then I'm going to release a quality improvement module, which is a different approach to understanding how we can improve patient care. It is typically done just at your site. It's not, and it's not considered research, but I think people are interested in what quality improvement is, and we have a module developed, so I'll go ahead and share that with you in the coming week. And we'll stay on for the next 15 minutes. If there, I know Julian, it looked like you had another question. If others have questions, Sarah, do you have until 7:30?
Yeah, I can do that.
Okay. Yeah, we'll stay on. And if you have more questions about study design or even the homework, post in the discussion and we'll get back to you. It was nice to see everybody.
Thank you, everybody.
Thank you. Have a good day.
Yeah.
Thank you.
Thank you, Sarah and Christy.
See you guys.
You all.
See you next week.
Bye-bye.
Bye.
Yeah, thank you, Ginger and Christy, and all you.
Bye, Jethro. Bye, Swen. Bye, Carla.
Bye.
Thank
Hi,
you.
Michelle. Nice to see your face.
Yes, bye.
Bye.
I enjoyed this session so much.
Oh, good. I'm glad.
Good.
I'm glad. Bye, Carla. Hi, Daisy.
Christy, just want to share something. I am amazed with the research that Sarah and her teams have done. I wish that one day Indonesia can do that kind of research because, there's a lot of limitation in our country, like the database that we have and something and other things like that. Also with how the team works going together. I'm so amazed with the research and I enjoy this session very much. Thank you, Christy and Sarah, for sharing.
Thank you.
Thank you, Astari. Your questions have been great in the discussion. Keep them coming.
Yeah, thank you. Good night. And good morning for you.
Do others have questions? Daisy, you did a great job with your homework.
Thank you. Goodbye then.
Bye. See you
Bye.
next week. Christy, do you have questions?
Okay, I was still muted. Hey. So the project planning, if I want to talk to you more about my project, would office hours be the best time to do that?
Yeah, send me your, if you have it, send me your project planner ahead of time. I'm much more helpful when I've had a chance to think about.
Okay,
stuff.
I will. Yeah, I'll do that. I'll finish that and send it to you. Anyway,
Yeah,
I guess that was
one thing. Yeah, I mean, one thing that just comes to mind is, I mean, you're at UAB, right?
right.
And that's where the practice-based research network is. You know, I mean, as you think about your project planner, I don't know that much about the practice-based research network, but I know they have lots of clinics, right? And
They do,
I don't-
and the
Yeah.
oral facial pain teams have, at different institutions have used them a lot in
Mhm.
looking at pain with TMD and pain with endodontics. I wonder, you know, when I'm looking at trying to assess whether people have temporomandibular or myofascial pain when they come in for root canal treatment, and if that increases post-operative pain. And I think about getting people involved at all these different practices and them having to learn how to palpate the muscles in order to make a specific diagnosis. That sounds like it would be kind of complicated in training everybody how to do that. Yeah, that was just something I was thinking about when I was, you know, during this talk and when I've
Yeah, I
been
think-
trying to plan the project.
Are there, you know, like with caries, we have things like ICDOS, right? It's very specific. There's a whole protocol about how we measure lesions.
Yeah,
Is there something similar for TMD? Is there a standard protocol that really specifies?
it does. There is one that I found just recently. And the specificity and the sensitivity is really high when you're palpating and trying to make this diagnosis based on trigger points that you find. The problem is, just like with endodontic diagnosis, there's kind of an art and a science to some of our objective tests. And I think there's probably the same thing with people, you know, trying to evaluate patients with myofascial pain. But that's stuff that I'll just have to, you know, look into a little bit more and talk to some people about, because I worry about that. Then I think about, well, maybe I could get all of this data myself here at the school. You know, and that could take a very long time. But
I guess
anyway, I'm just thinking out loud.
Yeah, no, I'm just thinking out loud too. I mean, could sort of what Sarah did act as a model? Like, is there sufficient data in the records that you could measure both your exposure and your outcome? And I guess the other thing too, before I would get to that, I would probably say step back and say, what's the state of knowledge? What gap could you fill that would be important? What do we know? What are the limitations of the existing studies?
Right. And we do know a lot about it.
Okay.
We're starting
like,
to know a lot about it.
Yeah, like what's the next, where can you add? You know, if you're a journal editor, you're looking at like, well, what does this paper add? Why is it important to publish?
Yeah, my mentor is suggesting, you know, looking specifically at, do endodontic patients that already have TMD, do they have more postoperative pain? And yeah, I guess that in his opinion, that is kind of the gap in the knowledge.
Is that supported by the literature?
I've yet to find out, but I'm going to. I've been writing down some questions that I think I'm going to do some specific research on chronic pain syndromes and TMD and post-operative pain in patients with TMD. And I think I'm going to get the help of a librarian.
Mhm.
One of the problems I'm having is that I'm so crazy, like busy, and I'm like, when do I have time to do all of it? But the librarians can be really helpful. I've heard in doing some of these searches for you.
Mhm. They're great. Yeah.
Okay.
They are great. They're an underutilized resource for sure.
I actually don't trust myself to search my own literature.
Right.
It's like officially, like if I need to officially do something, I will get the because they understand all the details about
Right.
mesh terms and all that I don't fully understand.
I just have to be able to give them the specifics, you know, I guess the project planner for why I want to do this and why this is important to understand. And
Yeah, they'll want to know like your research question, and you want to also give them like alternative terms that might be used.
Mhm.
And I think multiple meetings with them, like
Yeah.
it's a lot more useful when they've done a little bit and they come back to you and you're like, oh, well, I hadn't thought about that coming up. You're seeing all these results that get some term you could never have envisioned.
Right.
And so you can kind of change course before you get the results of a search that aren't actually that useful. So I think they can definitely do a lot with the search development but that kind of knowledge building. I mean, here at the UW, we have librarians for the dental school specifically. So they're more familiar with like dental procedures than our librarians that are in pediatrics.
So I have a question then. If there's like at University of Minnesota, they've been doing a lot of work on this. Could I use their librarian?
Probably not.
Okay. Could the two librarians talk? Because
librarians, they do talk, but they probably
work together.
You're not affiliated with the institution, so they probably wouldn't.
Interesting. But I would then maybe the primary investigator at University of Minnesota would be able to give me some guidance too.
Yeah, a lot of times I'll look at reference lists of really good manuscripts because they have old papers that you might not see in a search that are nonetheless really useful. So as I'm reading the literature too, I will I'll read something, I'm like, oh, that paper says this, and I'll highlight it or put a little circle by it in the written, hard copy, and then I'll go get those papers. So, and after a while, I think one of the things you realize you've saturated your literature research because you just see the same papers over and over again. You're like, okay, I thought there'd be more, there's not more, and you can so you can do a mix of things, but I do think there's value in looking at reference lists, particularly if somebody's been doing a lot in the field and they're really good at it. Sometimes people will publish sort of position papers. Like, this is where our state of knowledge is. It's not necessarily a review, but it's sort of like, this is what we understand about this problem, sort of a synthesis of knowledge. And those types of papers often have really good long reference lists that are nice and comprehensive. So between a librarian and you sort of doing your own work, but it does take time. And I know that when you're clinical and you're really busy, that's a challenging environment.
Well, I've got time carved out. I just feel like I really, really, really want to use a librarian a lot. And I feel like I don't know. I guess I feel like I should be doing the research myself, but I'm learning that the librarians are something that are, used a lot in academic institutions. So,
but I think there's searching the literature and then there's doing the review, and you're still doing the review because you're going to be the one that has to read all the articles.
Right.
But searching, and it doesn't have to be like 100% librarian and 0% you. It can be the librarian doing the bulk of the work and taking some of because I'm also a clinician and I get busy doing something clinically, and so can't pick up a project for a few weeks, and then I pick it up a few weeks later and I can't remember what I did, and it just takes more time. It's more inefficient. But if you're working with a librarian and you're giving them a bunch of information, they're going to go off and do their work, and you can go do your other stuff. And then when you meet again and you're saying, I'm getting these papers, I'm not sure why I'm getting these, and then kind of alter the search a little bit if needed. Then I'm always a rate limiting step in any project I'm doing. And finding ways to offload that so that you're not the rate limiting step is going to help you be more efficient in trying to do research and be a clinician at the same time.
Okay.
Yeah.
Okay. Did you have a question, Melissa? Do you guys have questions? You may not be there. So it's hard to know what's going on behind the scenes.
I don't think they're there.
Okay. Thank you.
All right. Yeah, Christy. Yeah, happy to help with your project as best I can.
Yeah,
So
I'll
send
keep
me
working
your-
on it.
Okay, sounds good.
All right. Thank
All
you.
right. Bye.
Thank you, guys.
Bye.
Take care. Bye.
Yeah, thanks, Sarah.
Sure.
Really appreciate you showing up. I think it's one of the most interesting classes. I feel like I should develop more of these sort of applications, kind of
Yeah.
projects.
Well, and I'm wondering about the, remember the R21 we wrote or for my TL1 grant?